Are there any issues you've come across, Sebastian, with people revisiting therapy after having decided to discontinue something or not been particularly successful, and they're having another go with their physicians with respect to naltrexone?
The one big thing that we've seen is patients who, if they've been on it for a period of time, they discontinue. They go 3 to 6 months, and then all of a sudden they're like, oh man, I want to come back to it. Or even a year, retitrate, kind of come back into it. So we revisit, and they titrate in, and they may actually end up at a different dose. Mainly because they may have different perspectives, they may have different lifestyle changes, they may have undergone different physiological changes. And as patients also get older, we also know that there may be differences in their hormones as well as their immune function. So we do see a change there, but if anything, we just see patients who actually respond a little bit faster, and they have this anticipatory, like, oh, I remember feeling better, and so they're much quicker and they have a better idea of where their target is. But certainly no harm or poor outcomes. It just might actually be like, oh, our dose is actually slightly lower, or it's different dosing patterns, which we're starting to see is people, when they're more comfortable with it and they're given that autonomy of trust as well as patient specificity to find their best path, all of a sudden they're like, yeah, I tried breaking up the dose. I tried something different, and I'm trying this modulatory dose. And I do want to say this, I have a colleague in California, and he's got patients who were on a split dose, but those 2 doses were vastly different. I think it was like 3 milligrams in the morning and 9 milligrams at night. And that's what worked for that patient. But given that difference of autonomy of trust to the patient, because they know what to expect and they have this plan of how they want to move forward, and as we have more emerging information, 4 times a day dosing. 2 years ago, we just heard about that, and I watch people's mouths. What do you mean? We can do that 4 times a day? Yeah, we have all this difference of ability in BID dosing. I think we've talked about this. You're super excited about it. So, again, no harm. That is the most amazing thing. If we get into the drug usage, as soon as you see side effects, your dose is too high, back down. And then all of a sudden, these patients are healthy. So, wild stuff.
On that question, I have most of my clients tend to titrate up really quickly compared to many of the patients that have been talked about here. Some clients will start at the target dose of 0.06 milligrams per kilogram dose per dose, but I always have clients start at half that dose or less. And some patients need to titrate it up more slowly. It may take 2 or 3 weeks to get up to a dose where they're not having any side effects with the target dose. If they go off it for a month or 2 months or longer and come back on, then they're going to need to repeat some version of that, likely, because it takes the opioid immune system time to recalibrate again when it hasn't had it.
So this plays under the question that I was just asking to come into you. So recently I've been, we were talking about playing with liquid dosing for patients to give them that autonomy. And so they might have multiple dosing at different doses during the day. I think autonomy is becoming a little more important, because if you go back to the question that was asked me, and I said, yeah, I didn't have great luck with that, but I was also kind of doing a very generic scheduled opinion like we did back then, and there was less sort of prominent relief that you see with the central pain because it's working on a different pathway. So retrying and giving that autonomy maybe lets us dial in for those non-central patients what they actually need. Maybe they needed a little more benefit towards the mood things versus, or the inflammatory pathway or whatever, than a central pain patient. So I think that's this strategy, which is essentially our dosing philosophy, not really, right, as we learn more, is gonna become a more important piece as we go on.
At our clinic, we use it sublingually. We start every patient on sublingual LDN, and that allows a lot of flexibility in dosing, and that's wonderful.